Fine. Okay, so we are now recording. So yeah, so as I said, this is a talk really about hopefully making you feel a bit more confident by the end of it that you can talk about the vaccine. So to do that, actually, we have to go to first principles and basics a little bit. We need to talk about actually what is a virus and what is immunity. And it's only when you start to understand those things that you can talk a little bit about how a vaccine works. And then from that, you can start to then understand what we're talking about when we talk about the Oxford, Astrazeneca and Pfizer. And then you can understand about safety and effectiveness. And I think that's really important because as doctors and as clinicians, we obviously have had training in this and we get these steps. So when we talk about it and we say, oh yeah, it's safe, don't worry about it, there's a huge disconnect from people who don't have those steps. And you know, you're getting information a lot through the media and there's lots of different things. So bear with me, the first 10-15 minutes might be quite dense. It's me trying to explain immunology in 10 minutes. It took me 6 years at med school and I still didn't quite understand it. So yeah, but hopefully it does make sense. And as I said, this is all based on NHS online training that is there for volunteer vaccinators. So this is stuff that is being opened out to the public. I was gonna ask now, but we'll leave it to the end. But I will want to make sure that we've covered any burning points that anyone has in the group. So I will ask questions from you guys at the end. Okay, going to start with what is a virus. Anyone want to shout out any thoughts on what a virus is? You don't have to. I can't see everyone's face actually. So if there is anyone who has anything to say, just please shout it out.
Not a bacteria.
Yeah, that's a good start. Lots of doctors sometimes forget that. Yeah, so a virus is, the simplest way to put it is, first of all, we just need to recognize that it's a living thing. It's a cell. It's a very basic living thing. It's consisting of basically just a cell. And if you look under a microscope, the image on the left is kind of what you'd see. You'd see these simple structures, usually sort of round or oval in shape. And they're basically like tiny little balls, very, very, very tiny, but tiny little structures that have a shell. And on the outside of the shell, you'll see some extra bits stuck to it, put simply, and which we'll talk about as spike proteins. And that's basically all it is. It's a one cell organism with a very basic structure, usually sort of ovaloid or circular shape with things stuck on the outside. And then if you look at the diagram on the right, so that's sort of a pictorial form of that. If you were to look inside this structure, basically all you'd find is a strand of RNA. Now, RNA is genes, right? So it's genetics. So it's a bit like when we say, I blame my genes for looking like this, how tall I am, how short I am, how fat I am, what color I am. The same with this virus. Every detail or instruction of how the shape of this virus is stored in this RNA. So the size of it, which spike proteins or things it has stuck on the outside, how long it lives for, all of these things is stored in the genetic material that's on the inside of this virus, and that's called RNA. And that's this sort of stringy stuff that you can see in the middle there. So these are sort of important terms that you've obviously all started to hear about, spike proteins and RNA and stuff like that in the media. Now, the key thing about viruses is that they can't replicate. They can't reproduce themselves. So they have no way of creating babies, basically, or new viruses, right? So the only way they can do that is to basically latch onto or use another cell's ability to reproduce, okay? So it needs a host, basically. So it's a bit like a parasite almost, if you think of it in that sort of terms, right? It needs to be in someone else or in something else that can reproduce, and then it will be able to spread its material and replicate as well. And that's really, really sort of a key component of viruses. And so here's some diagrams I've got. So just showing you that as simply as I can. So if I talk about the one on the left then, so what the virus will do is it needs to find a host. Now, a host is basically any other living thing. So it could be a plant, it could be us as humans, it could be any other animal. And if you think about living things, we've got lots of cells that are reproducing all the time. So if you think about ourselves, our skin cells, you've got your dry, flaky skin cells that you have that you brush off, and then you've got new skin cells that are growing underneath. Your hair falls out, new hair grows back. You drink too much, your liver gets damaged, new liver cells grow, so your liver regenerates. Your red blood cells, you take some red blood out, you get new red blood cells. So literally every cell in our body is regenerating all the time. So the virus, what it tries to do is to get into one of these cells so that it can use that capability of regenerating or replicating. And the way it does that, very simply put, is on the diagram on the left here. So you've got your virus, so that's the diagram, that's the structure we're just talking about, your round shell, proteins on the outside, the stringy RNA on the inside. It finds the cell, which is this big sort of beige gray thing at the bottom here, and it will latch on. So this spike protein, this thing on the outside, will find a way of connecting with the host cell, with the human cell. And once it's done that, it sort of tricks the host cell into allowing the virus to almost inject its RNA into the host cell. Yeah. So just to run through that again, the virus needs a host. It will find a host cell. It's got its external little spike protein that will latch on to whatever the cell has, the host cell has. By doing that, it tricks the host cell, and then the host cell opens up, and the RNA, the genetic material of the virus, gets in. And then then you can move over to the diagram on the right here, and you can then see, so that's the top picture here on this cycle. And then you see, as we move sort of clockwise around, the RNA gets into the host cell. Then the host cell, whatever that is, so that could be a red blood cell, that could be a lung cell, a liver cell, as it's replicating or regenerating, it inadvertently also helps the virus RNA replicate. And so lots of RNA is produced of the virus. And eventually the cell, the living cell, the host cell that was sort of infected, gets overwhelmed and breaks up. And then the virus has lots more copies, and then it spreads. Okay. Hopefully that makes sense. Anyone want to just shout and say if it doesn't make any sense? Please do ask any questions.
Vic, we did have a question from someone that hasn't joined just yet.
Yeah.
And she was concerned about the transmission of, or the crossing over of the virus from animals to humans. And you did mention that cells, that you did mention live things, that animals, people. How big a concern should people place on that? Is that something that we can dismiss, or is it something that we should try and stay with?
It's a really good question. And actually, I'll come on to that when we talk about why this virus per se has overwhelmed us. Yeah?
Great, thank you.
So yeah, I will come on to that. So this is the basic premise, basically, of any virus that we talk about. This is how viruses work. Now, viruses, so the virus's ability to infect a host cell basically is very dependent on this red sort of protein on the outside, this spike protein. And this is different for different viruses. And this is where you get the difference, right? So some viruses will be very well adapted at attacking your lung cells. So there'll be a virus that affects your lungs. There'll be other viruses that are very, very good at connecting with and attacking your liver cells. And they will be viruses that we know affect your liver. And just from what Graham was saying, viruses have adapted over thousands of years. So some are very good at adapting and connecting with human cells. Others are very good at connecting and adapting with other animal cells. So that's why you've got certain viruses in certain animal species and certain viruses in other animal species, right? So viruses that we've lived with all the time. So just moving on from what I said. So the flu. So we talk about the flu. That's a virus called influenza. Okay. The common cold. That is actually a coronavirus. So coronavirus is a family of viruses when we talk about coronavirus, right? So the virus that we have now for the pandemic is the COVID virus, which is a subset or is a member of the coronavirus family. Okay. So at the beginning, when we were first hearing about it spread through the world and stuff, we knew it was a coronavirus. So everyone was talking about coronaviruses. But now we've defined it, we know what it looks like and stuff. So we've specifically called this one COVID-19. So this is the COVID-19 member of the coronavirus family. But there is another member of the coronavirus family that causes us the common cold. So it's a virus that can latch onto the back of our nose, the back of our throat, make us give those sort of symptoms. Norovirus knows how to connect with our gastric cells. So when you hear about hospitals having to close down because a stomach bug has gone straight through a ward and caused loads of diarrhea and gastroenteritis, that's the norovirus. Chickenpox, that's a virus. Varicella, mumps, measles, these are all viruses that we live with and have lived with for many, many years. Okay, so our immune system. We are all the time creating cells in our body that we call antibodies. This is part of our immune system. And what they are doing is they're floating around our blood and they're looking for invaders. They're looking for foreign cells that can come into our body and attack us. The medical term for these foreign cells or invaders are antigens, okay? So we've got antibodies that we produce floating around in our cells that are looking for antigens. And it's actually quite once you start thinking about it, it's an incredible thing. It really leaves you in awe of our human body and how nature works. And basically these antibodies have sort of are made of certain shapes that are floating around, and if they can connect, if they lock in with an antigen, with a sort of foreign invader or an alien, then you get this sort of lock and key mechanism where the antibody and the antigen connect together. And hopefully you can see that in the diagram of the slide. So you've got your antibody, which is on the right, and then you've got the virus, which is on the left. And you can see the spike protein in red there fits exactly with the antibody shape. And so once those connect, then that sets off a chain of reaction in the body where the body suddenly alerts, oh, there's something here that is an antigen. This is invading our body. And it sets off a set of reactions in the body that further cells are then released from the immune system. That means that we suddenly upscale, we increase the level of antibody that we make. We say, right, we've got this antibody, it's locked in on an antigen, we need more of these antibodies. So we suddenly upregulate this antibody a lot with this specific shape. And then once the antibody has got out and locked onto all the antigens, all the virus particles, then other cells in the immune system can identify these invaders and destroy them. Okay, so there's a whole system that's in place in our immune system to do that. But what's key to that whole process is that you have an antibody that first reacts, first recognizes and locks onto the antigen. Okay, so there's this really important lock and key mechanism that happens. And then once our body has recognized the virus, has created lots of antibodies to make sure it captures all the viruses, and then created cells to destroy and kill the virus, what the body does very cleverly is it says, you know what, we'll keep some of this antibody in circulation just in case this virus comes back. Yeah, so it will remember, it will say, right, this is a virus that might come back, so we'll keep an increased amount of this antibody in the system just in case this virus ever comes back to us. And that is what we call immunity. Yeah. And that is what I was talking to a bit earlier about when we talk about being exposed to lots of viruses in childhood. So as a child, we have lots of coughs and colds all the time when you go to nursery, when you're, playing with friends and stuff like that. And constantly, if you've got kids around, you'll see they've got a runny nose or a cough. And that's because this amazing process is happening on a continual basis in kids, where they're creating antibodies, they're learning about viruses, then the immune system is saying, right, we recognized you, we're going to remember you. And we're going to keep sort of memory cells in our system. So that by the time we get to adulthood, we're not getting coughs and colds constantly because we've got antibodies now ready and primed. So every time one of these viruses comes to us, we've got a ready-made solution where we've got antibodies to kick in and latch onto the virus and consume and destroy the virus before it ever gets to a point where it can start destroying our cells. So we don't get any symptoms. So this is constantly happening in the background. Make sense?
Yeah.
Shout if there's any questions. Cool. Okay. So
sorry, can I ask a question, please?
Yeah.
Yeah, the question goes like this. Concerning mutation, why does the virus mutate? Is that a natural process or is a special reason why it does mutate, please?
Yeah, no, great question actually. I haven't actually got that on the slide. So if I just go back to let's see what slide. So if I go back to this slide, maybe. So this process where the virus injects some RNA, the genes, into the cell, and then the cell replicates lots of those genes, and then you get more viruses. Now that process doesn't happen perfectly each time, right? So it's not like that RNA in that virus, the original virus, when it's injected, that RNA stays exactly the same, and so you have exactly the same copies, which creates exactly the same virus. What actually happens in real life is that strand of RNA, which is made of proteins and things without getting too complex, there'll be slight changes in it. Yeah, so it might be that the host cell causes a slight change in it, or a little bit of it fragments off, or there's lots of things happening all the time where these RNA cells change slightly. And so that means when you get the new viruses being produced, they might be slightly different to the one that originally infected the host cell. And so what you've had happen is a mutation in the virus. Yeah, so this virus had a certain number of proteins and things stuck to its surface, which is coded by that RNA. But because that RNA has changed in that process, these new viruses that come out might not have the same number of things stuck to its surface, or the things that are stuck to its surface might be of a slightly different shape. Yeah, so that's what we mean by mutation, and that is a natural process. So that's happening all the time in all living cells which replicate. Okay, so it's literally, so in skin cells, it's why we get freckles or moles and things like that, because some cells just replicate slightly differently. It's why as we get older, our cells aren't so good at replicating, so our hair turns from black to gray, right? So there's certain things that are affecting the way we reproduce cells. That means that they're not the perfect copy of what they were before. So mutation is a natural process that we can't do anything about. And sorry.
Very, very interesting. We don't need to do a GCSE in this, but where I'm interested in how different people are reacting differently. So within a family, even some people can get a severe reaction.
Yeah.
Is that because their immunity, and with this new variant, it seems to be affecting different age groups. It's quite tricky then for us in a group, intergenerational group, to know what to do for the best. Perhaps you'll discuss that later.
Yeah, no, so yeah, I know it's about now that we're discussing that. So yeah, another great question. So basically, so in the end, actually, if I go to the next slide, that will probably help answer that. So why aren't our bodies fighting off COVID? So if we've got this immune system that's so good at creating antibodies and lock and key and upscaling very quickly and then finding, why is it not happening? And this sort of wraps in a few of the other points that were made. One of the big things is it's new to us, right? So we've not had the chance, like we usually do with most human species viruses, to learn about this as we were growing up. This is something that has suddenly been introduced to our immune system out of the blue in adulthood. So our system hasn't got memory cells. It just now needs to rapidly adapt and figure this out. And how quickly our immune system is able to adapt and figure this out is really linked into how healthy we are. So people who have all sorts of health conditions, from diabetes to lung respiratory disease to being sort of more frail and of older age, their immune system and the way their cells react to this virus will be impaired or affected. And therefore they are at more risk of being overwhelmed by this virus when it enters them than someone who's got a much healthier body with an immune system that is working very quickly and very effectively. And that's part of the reason children don't get sick so much, because their bodies are very much in that world, right? They are used to, their bodies are almost used to getting lots of new viruses all the time and very quickly reacting to them and overcoming them. And also they're healthy. They don't usually have chronic diseases at that age. so they're not impaired in any way. So that's why you're seeing that children don't end up with the serious disease so much, unless they've got already, unfortunately, some other serious illness that puts them at risk. But obviously, the longer we live, the more impaired and ineffective our immune system gets with all the other conditions that we have.
Yeah, and just on that point, many of us older age, over 60, 65, over 68 now, are on tablets for various ailments, post-stroke, post-everything. Does that make them more frail, or by having those particular treatments less frail, or is that more shielding? That's one of the main things for me personally.
So and this is where it gets a bit confusing. It's the condition that makes you more susceptible, right? So it's not the treatment. Okay, so if you've had a stroke, by all means carry on taking your stroke medication. If you've got heart disease, by all means carry on taking your heart medication. You want to make sure those things are optimized and are as good as they can be, so that your body's as healthy as it can be, and it can fight the infection if it does get infected. Max, I saw you had your hand up.
Thanks. Yes, a question now. You may wish to answer it now or later. I don't know. Two things have come up in my contacts and work. One, are older people, say over 80s, shopping in the local Tesco or Sainsbury's at greater risk of infection from a group of young, healthy-looking students when they get close? And secondly, is an older person at risk if a young person's dog jumps up and gets friendly with the older person?
Yeah, good question. So I'll come on to transmission a little bit. So I think transmission from people to people is the same no matter which people they are, right? So it's to do with whether the droplets that contain the virus get into your body. Yeah, whether you get them from young people or old people, if that person has got that virus on them, and then you've not maintained the safe social distancing and done the hand cleaning and all of that stuff, then that transmission can happen. So it's not really about what age group that other person is who's got the infection. It's about how safe you are. As far as whether you can get it from animals, to be honest, I'm not 100% sure, but that would depend on whether that talks about how humans can transmit viruses back to the animal, and then the animal can transmit the virus back to humans, right? So you've got someone who's got the infection, gives it to their dog, and then the dog gives it to someone else. Now, from my understanding, that's very unlikely because we haven't seen huge numbers of pets and animals going down with coronavirus. So human to animal transmission, I think there are cases of it, but it's, from my understanding, not a huge thing. But that's not something, I think that would be something I'd have to go away and give you more information on. That's not something I think I can give you a fully informed answer on. Okay, so that's very nicely moving us into the next slide. So this is literally just taken from the NHS training that that people are getting. And if you look at the diagram on the right, it talks about transmission of virus. So you've got so we can start at the top if you want. So you've got your infectious microbes, so COVID, or the sort of the technical name SARS-CoV-2 virus. It then finds a place, a host, and that's its reservoir. So that's the infected person. So it lives and replicates in people and animals. It then has a way of exiting that host. So that's your coughing, sneezing, talking, you know, all those videos we're seeing on the news at the moment of particles going out into the air. So that's the virus sort of leaving the host. Then there's modes of transmission. So that could be you standing or sitting next to someone with the infection. So as the virus particles leave one host through coughing or sneezing, you then inhale them, or the person that was sneezing, it's on their hands, they've touched something, and then you touch that same thing, and then your hand comes to your mouth, and then you've got the particles hitting your mouth. And so critically what happens is that the virus needs to get to a part of your body where your it can infiltrate basically, and that's what we call the mucosa. So that's the inner lining of your nose or mouth. So our skin is actually a barrier, right? So our skin, one of its main functions is it's actually our first line of defense. It's really, really good at stopping bacteria and viruses getting in. We don't have that level of defense on the inside of your mouth, on the inside of your nose. So that's why if you touch something which has the virus and it's on your hands, as long as you wash your hands really well, you're not going to get the infection. But if you haven't washed your hands really well, and then you grab an apple and eat it, or you pick your nose or whatever, you've introduced that virus to the mucosa on the inside of the mouth or the nose. That's when the virus has opportunity to get in. So that's where this whole thing about washing your hands is so important, because as long as it just stays on the outside skin and nowhere else, you won't get infected. And then once it's into the mucosa, then it's into a susceptible host, and that ties into what we were talking about earlier about who is more susceptible than others, and how effective that immune system is. So hopefully you have an immune system that deals with it, but if not, then that virus can then start replicating in the new host, and then that whole cycle is replicated again. Okay. And so with COVID, what we're seeing is that, so in this triangle, that when you get people who are infected, you've almost got like a pyramid of how severe it affects people. So the bottom of this triangle, the asymptomatic, so people who don't get any symptoms to very mild symptoms. So these are people who basically have an immune system that was able to rapidly identify the coronavirus, the COVID virus, upscale the antibodies, and get rid of the virus before the virus has had any real ability to cause any symptoms or affect the lungs or or cause much of a fever or anything. They're the asymptomatic, and that's about 80% of people. So that shows you that even though this is a completely new virus to mankind or to the human species, still our immune system is so amazing at what it does that 80% of us will still manage to quickly identify and nullify the threat without ever being bothered by it. Unfortunately, as we move up the diagram, up the triangle, about 15% will get quite severe and will need hospital admission. So that means that their immune system hasn't been able to respond well enough. The virus is now in the person's lungs mainly. It's the lung cells that are being overwhelmed and are being destroyed. That means that they're not able to breathe properly, or there's too much fluid and inflammation and stuff in their lungs, and therefore they're not able to get the oxygen in, which means they're getting very, very breathless, and they need to be on oxygen in hospital. And beyond that, there's then unfortunately another 5% who get so overwhelmed by the virus that the lungs basically just can't work for themselves. And not only that, but the virus is sort of not only affecting their lungs, but now the body's gone into such overdrive. It's really trying to, it's getting so overwhelmed basically that other parts of the body start to shut down as well. So the kidneys might not be working so well, or the heart starts to become inflamed and stuff. And that's when you're critical, and that's when you end up in ITU and you'll need to be on ventilation and stuff like that. And so that's about 5%. And then we get to the top of the triangle, which is unfortunately we see estimates vary, but about 0.8 to 1% mortality. But that's heavily skewed. So that's heavily skewed by people in older ages. So there's almost no one below the age of 50, or very few people. So if the lower you go, there's hardly anyone. So right, so if you go below the age of 18, very, very few numbers. We're talking, numbers you can count in your hands. And then as you go up in the ages, it increases. So by the time you get over 80s, it's much, much higher. So when you average that out, it's 1%, but actually, when you look at age groups, it's much, much higher in the older ages. So going on to the next slide. Right, what we're going to start talking about then is the vaccine. So hopefully that gives you sort of a good sort of basis then of what is a virus, how our immune system works, and how we get overwhelmed and who's at risk. And it's once you know all of those things that you start to think, right, if we're going to remedy this, we need something that can help our immune system react very quickly to this virus, or how can we prime our immune system to make sure that if our bodies are attacked by the virus, our immune system is ready to go. And that is basically what your vaccine is. That is the job of your vaccine. Okay. We've had vaccines for a long, long time, as we all know. We have vaccines for all sorts of things. You have vaccines when you're a kid. You have vaccines when you go traveling. And we have vaccines when we have to do certain jobs. So the way we design and create vaccines has actually been around for a long, long time. And there is a specific process we go through where you do phase 1 cell trials first. So you basically create a vaccine that you test on viruses in Petri dishes, so in a lab. Then you go to sort of phase 2. Then you go to the next phase, which is sort of on a small group of people, who are very, very healthy and very low risk, just to make sure that they don't get any sort of adverse reactions or allergies. Then you scale up to phase 3 trials, which are done in the thousands. And that's when you can really start to create the evidence around whether this is an effective vaccine across the population. And though that process is what has happened at an incredibly impressive rate over the last year. Now, none of these phases were shortened or shortcutted. They were all done. Okay, it was just, for me personally, it just shows what can be achieved when there is the will, the global will and the financial will, and you get a whole bunch of people around the world saying, right, let's do something here. You know, I think that for me is the big learning out of how we've managed to create this, rather than any anxiety I've had around, oh, how have they done this so quickly? And I think a bigger question to medicine and science is actually, if we can do it so well for this, why aren't we doing it for other things that are around the world and have been in sort of developing countries, or people are suffering, that, you know, doesn't have the global will or the financial power behind it. So all these phases have been done, phase 1, phase 2, phase 3. And it was when phase 3 was done and the results came out, that was the stuff we were hearing about in the news, November, December, when Pfizer came out and said it works 95% effective. And then the Oxford one came out as well, saying that it was 70% effective as well. So that is how the process the vaccine goes through. And so this is, again, just slides that I've taken from the NHS learning thing. So yeah, tens of thousands of people have already received the vaccine. No serious adverse reactions were seen to the vaccine when the trial participants received the vaccines. The only reactions that have been reported today are similar to following other vaccines. So just like if you went in for your flu jab or certain other travel vaccines, so there's some soreness at the injection site. You can get a mild fever, headache, muscle aches and fatigue, and I'll come on to why that is when we think about what the vaccine is doing. And once you have all this data, we then have the Medicines and Healthcare Products Regulatory Agency, which again is a term you've been hearing a lot about in the news, the MHRA, and they're an independent sort of regulatory authority that looks at all the evidence. So they're not associated with Pfizer or Astrazeneca or Oxford or anyone, and they will look at all the evidence, and then they basically take on the responsibility of saying, yes, this is safe. And as a doctor, any prescription that I do has been cleared by the MHRA. Okay, so when I'm telling you stuff about a medicine and how safe it is, I'm relying on MHRA guidance ultimately. Yeah, so whether that's your paracetamol all the way through to chemotherapy. Okay, so these are the sort of the people who provide that oversight. And the only thing that has been sort of rushed through, as you hear when you hear about rushed through, is not them how they've looked at the evidence or how they've decided that something is safe. It's more the bureaucracy around it. So normally when a medicine is licensed, it goes through various panels to be licensed, to sort of be signed off, and documents are created and things like that. So what they've done is they've created there's a regulation 174 that's basically said, we're in the middle of a pandemic, it's a national crisis, we're not going to go through all that bureaucracy to get all these signed off documents and stuff like that. MHRA can just come out straight away and issue sort of national guidance on it, rather than it sort of being filtered down to local NHS and local suppliers and stuff like that and things. And so then that allows us to act on it. And so that's what's been going on in the last month. And how do vaccines work? So this is how the training session talks about it. So it talks about vaccines deliver components of the antigen, and what that does is that then triggers our immune system to create antibodies and remember having antibodies, and then store those antibodies for the actual virus. And I think that's probably more easily explained when I come onto this slide, when I talk specifically about the Pfizer vaccine and the Astrazeneca vaccine. So starting with the, I'll just pause there because I just realized I've been talking quite a bit there. Any questions or thoughts at that point? No? Okay, so the Pfizer vaccine, which we talk about on the left, you'll hear a lot about it being called the mRNA vaccine. And now we know what RNA is, we can imagine what the vaccine might be doing. Yeah. So what they're basically doing in the vaccine is that they have found key parts of this RNA that we can put into our system that will make our host cells create bits of the virus. So not the full functioning virus that is active, but bits of it. So it might create a couple of these proteins on the top there. So it won't create the full structure. It won't create something that's living, which is wandering around, which has got its own RNA in a circle and all these spike proteins on the outside, but it might create a little segment of it. So a little bit of the protein just there, for example, right? So you put the RNA in the host cell, it produces just that little segment, and that little segment is enough because it's a sort of, it presents as a foreign object or an invader or an antigen to the body and the immune system. Our body then creates an antibody that locks onto that bit and locks onto that segment. And that's very safe because you don't actually have an active virus that's overwhelming as host cells or doing anything like that. You've just got this inert segment of virus that's been created by this sort of fake RNA, really, that the body has had a chance to safely identify, create some antibodies for, and then we've got those memory cells. We've got those antibodies sitting and waiting for us. So that's one way you can create those antibodies. The other way you can do it is that you can take a virus that we know and that we can manipulate really, really easily. You can make it inactive, so you can switch off the bits in it that make it very aggressive or spread very quickly. So it's a very sort of inert virus, we call it, or inactivated virus, and we can do that genetically. We can cut off certain bits of it, and then you introduce it to the body, and so you get this full process happening, but the body actually isn't infected or affected by it at all, because the virus doesn't have the things that overwhelm the body or are aggressive or a danger to the body. And that's an inactivated virus. And so you introduce the RNA that way, and then the body learns to adapt to that and creates an antibody to it. So those are the two sort of basic ways. You either just directly inject in some RNA, or you inject in an inactivated virus that the body learns to deal with. And both of these are really safe. The Oxford vaccine, the inactivated virus, is one that has been done. Is sort of a traditional, sort of old school way of doing it, and I think that's where some of the feelings around it being the one that, oh, we know this is a trusted way of doing it, and some people feel safer with that. I think that's where that's coming from, because that's been done for years and years and years and years. But the mRNA one is not new. It's technology that we've known about for a long, long time. Yes, this is the first time that we've upscaled it to this. We've produced it for a mass vaccination. But again, I go back to my point. I think that's more to do with the global and financial will to do this time. But the actual technology behind it for both of these we've known for a while. So there's no worries about either of these technologies, and it has been done, as I said, for different viruses and other vaccines. And so yeah, so that's how these two vaccines work. We basically create a safe way for the body to be exposed to parts of the virus or to an inactive version of the virus, which then allows us to have an immune reaction or an immune response, which is our antibody response. Now that process of creating antibodies, that's a reaction going on in our body. And if you remember your chemistry days, any chemical reaction produces heat and sweat and inflammation. So that's why we might get for a day or so after the vaccine a bit of achiness, a bit of a fever and stuff like that, because there is a reaction going on in our body where our immune system is identifying something new and creating antibodies. So that's why we say to people, when you've had the vaccine, you might get a bit of a fever, you might feel a bit achy. That doesn't mean you've got the infection now. That's just your antibody, your immune system kicking into response and having a reaction to this, and that's a good thing. Okay, so moving on to next slide. So I'm aware of time, and I'm aware that there's a lot of information I'm giving you. So I'm going to sort of wrap up with some key things now. So hopefully I've talked to you a little bit about what the virus is, what viruses are, how our immune system works, how we create the vaccines and how that happens, how vaccines work, and how why sort of clinicians aren't too worried about them not being sort of effective, and why we're quite confident in the methods used. So I'll just talk a bit more practicality about this coronavirus, these COVID vaccines then, and what we're actually going to do. So you're probably all aware of this, but at the moment, based on the evidence of who it affects the most and who's most likely to be overwhelmed by the virus, you can now start to see why we set up priority groups like this. So residents in care homes for older adults. So you've got buildings with people with weakened immune systems or ineffective immune systems in close proximity with each other. That clearly is your highest risk of people. So that's why they're right up there at the top. Then you move on to your everyone else, 80 and over, and then you've got your frontline health and social care workers who may not have immune systems that might be overwhelmed, but they will be people who are seeing everyone else. So you can imagine that they will be effective passing it on to others. And then you can move through all the others. So the over 75s, the over 70s. And once you get to over 70, then what the guidance is that you're then talking about a group of people who have the same sort of risk as other people who are under 70, but have health conditions that make them very vulnerable. So that might be people who are on chemotherapy, for example, or have serious types of heart disease or things like that. So things that mean that they are at very high risk of suddenly being overwhelmed by the virus. So the judgment is that people over 70 and people at any age with one of these underlying conditions are of roughly the same risk. So that's why you can see priority group 4 is that we start vaccinating both. Then you go down to anyone over 65, and then you move to your 16 to 65. So when you hear in the news about us wanting to get through the first 4 priority groups, that's your top 4. So what the politicians are saying at the moment is we try and get to everyone in those top 4 groups by mid-February, end of February. And once you do that, knowing what we do about who gets that 15% who get severely ill and the 5% who are critical and the 1% who die, you will massively reduce that number once you've got those immunized. You are then left with the 80% of the population who have asymptomatic or moderate symptoms with the virus. And so that's the thinking behind that. And then let's just move on. So this is just about the priority groups and older adults. So you can see there, so 80% of deaths have been in those aged 70 years or over. Yeah. So that's just reinforcing that thing. And then clinical risk groups. So who's at risk? So these are people who are at risk of being more affected by coronavirus, and you can see these are things that you'll have seen as we've talked about, people who have to be extra careful over the pandemic and who are shielding. So these are people who are at risk, yeah, and then you've got in amongst those people at risk. So if you just see the top, so this is clinical risk groups, and the next tab along there is clinically extremely vulnerable, CEV. So it's the CEV patients that are the ones who've been told to shield at all costs, the ones that shouldn't leave the house. Now that's not everyone on this list. So within this list, there's a subset of people that are extremely high risk, who have been told to shield. And I haven't got that list on me, but I'm happy to share that with the part of this presentation. So going going back to the priority group, when we talk about priority group 4, it'll be everyone over 70, and it'll be the people who are extremely vulnerable, the people who've had to shield pretty much for the whole pandemic. Okay, and then, as I said, I'll share that group with you. Fine, okay, and I just want to end on a thing that I'm quite sort of passionate about, which is the inequality that coronavirus has shown us, right? It's really driven through deep-seated inequalities that sit in society already. Coronavirus has affected people who live in worse housing, certain employment groups, certain ethnicities more than others, right? And so you're seeing that you're seeing this inequality play out in who gets infected, who ends up in hospital, who's getting serious complications. You'll be aware of a public health report that came out last year that identified that people from BAME groups are at higher risk. Now, there's a lot more that we need to understand about that, okay? Because it's not just a case of, we don't know if that's a genetic thing. So there's something within the genetics of people who are from African, Indian, Asian, Caribbean backgrounds that puts them at increased risk or more susceptible to the virus, because there's lots of other things going on. We know there's other societal inequalities, right? So people from BAME groups are more likely to be in poorer housing, low-skilled employment, or places where there's not good employment conditions and things like that. Often much more frontline and exposed, if you think about your bus drivers and train drivers and things like that as well. So there's a lot that needs to be teased out there as to why it is we've seen this discrepancy. But what we do know is that BAME groups are increased risk, and people who are in certain occupations, in certain household sizes, certain deprivation areas are all at increased susceptibility to COVID-19. And then, and so this is being, we've seen this in the media, but then what worries me is that Royal College of Public Health, they did a study just before Christmas where they surveyed people on who was up for taking the vaccine. And 3 in 4 people, so about 75%, said they would. But if you broke that down to ethnicity, there was a big difference. So you'd go from anything about 50 to 55% for Asian, sort of Southeast Asian population, all the way through up to sort of 80% for sort of native white English speaking residents. So there's a big difference between sort of groups. So although you've got the average of 76%, there's a big variation. And my concern as a GP is we already are seeing the inequality of the virus and how it affects certain people. And if we can't get the message out and encouraging communities to engage, ask the questions, be reassured and take the vaccine, what we're actually going to see is a widening of that gap and a widening of that inequality as some people get protected and others don't. And that's why I'm really keen to do these sort of sessions and really thankful for all the support that you're providing. And so there's a bit of text on here that's quite important. As I said, I'll share the slide, but what this slide really talks through is when you're on the ground, this is some of the advice that we're being given as GPs and healthcare professionals. It's really important to recognize that being hesitant about taking the vaccine shouldn't be demonized. That's not a wrong thing, right? Even I would say that's really valid and that's fine to ask questions, okay? We do it with every other medicine. As a GP, a doctor, people come to me and say, should I be taking my diabetes tablets or my blood pressure tablets? So I think it's absolutely fine for people to be asking questions and seeking reassurances. It's how we bring those questions out and how we then are able to offer those reassurances, and also make sure that we can make sure that these questions are answered with trusted, reliable sources. Because in the age of social media, there's so much information out there, and it's not all true. So I'm not going to talk through this slide, but it will be shared it will be on the shared slides that I give you. Have just a look through that and just give some general principles about how you would address concerns when you're talking to people about having the vaccine, and also finding about where they're getting their information from. And I'll finish with this slide. So this is, and I've deliberately left this at the end because this is the sort of stuff that will change and can change. But right now, if you get asked who can take the vaccine, and this is This is for both vaccines, the Oxford Astrazeneca and the coronavirus, and Pfizer vaccine. Anyone over 18 is licensed for. Breastfeeding and being pregnant is now allowed. Okay. The only reason it's not allowed is because it's a new thing. To be honest, there's been nothing in the phased trials that suggest that this is something that will be dangerous to pregnant women or breastfeeding women. There is nothing in vaccine history that suggests that this will be dangerous, but because it's new, we're just being cautious. So what we're saying is that it's a case-by-case thing. The woman needs to feel informed, have that discussion. It's best to have with a healthcare professional, and then you make that joint decision. You can take this vaccine even if you're taking medicines that affect your immune system. So I know a lot of patients are worried. They will say, well, this vaccine is trying to stimulate my immune system. What if my immune system is really weak because I'm taking certain medicines? You know, should I still be taking it? Actually, you're exactly the sort of people who should be taking it, because we need to help your immune system be ready and primed to fight the vaccine, fight the virus when you get it. And remember, hopefully now you understand the way the vaccine works. It's not an active virus. It's not actually, it's not anything that can overwhelm your immune system. It's just little segments of virus. So you're absolutely fine to take it. And on a similar principle, people with HIV who worry, because obviously that's the disease that suppresses your immune system, you can take it. There's no concerns about that. The only people who can't take it, therefore, are people who've got an immune system that reacts to vaccines. So if you've got a history of allergy to this vaccine, so say you've had the first dose and you've swelled up, or you've come out in hives or itchiness and stuff like that, then you've got an actual allergy to the constituents, the ingredients of this vaccine, right? And so that's the reason you can't take it, because we don't know how severe your next reaction will be. Or if you already know before you've taken the vaccine that you've been told you have allergy to any of the ingredients in the vaccine. Now you're going to ask me, what are the ingredients of the vaccine? I will share them. They're on the patient leaflet. I don't know them off the top of my head. They're not hugely, they're not the sort of ingredients that are known to cause many allergies, to be honest. So it'll be very, very, very few people that will have allergies to the ingredients of the vaccine. But again, if you've got any concerns about that, then the best thing to do is discuss it with the GP. Okay, so I think that's where I end. So I will stop sharing now. Hopefully that was helpful. I will. We've run the hour, but yeah, I'm happy to take some questions for 5-10 minutes. Max, I see your hands up. I can't see everyone actually, so please shout, or Graham, I don't know if you want to cheer, but yeah, but Max, I'm happy to answer your question first. You're mute.
Max, your mute's on.
Thanks, Graham. Still learning about these things. Thank you for a fabulous presentation. A couple of questions arising. The first one is, if we have two, say, 81-year-olds meeting somewhere, yeah. One has had a vaccination, the other one hasn't.
Yeah.
Can the one who's been vaccinated still pass on, or is that person still contagious? Yeah. Do they still contain a catching vaccine? That's the first question. The second one is, and I'm sticking my head above the parapet here, we know, although we can't say, we don't say, that BAME people and Eastern Europeans are overrepresented in non-mask wearing and general sort of reluctance to participate in any program. How can we deal with this in trying to increase the 55% or whatever it is for BAME people in order to achieve at least the 75% we're going to need to keep this thing under control?
Yeah, thank you. No, good question. So just the first point. So the first question I think really highlights where at a time like this, where there's rapid learning going on about a virus and all the mutations and everything, the most important thing we can do is be almost overly cautious and give a consistent message. So in theory, being a medical scientist, I would expect someone who's been vaccinated, who can no longer get be overwhelmed by the virus, will have a very low amount of virus on them to pass on to others, right? So in theory, they've got a very low risk of transmitting it. However, we don't know that for certain yet with the virus, yeah? So at the moment, the message has to be very clear that even if you've had the vaccine, you still maintain all the standard social distancing, cleaning your hands, space, face, all of that you maintain. Okay, we don't want to mix messages and confuse people. Okay, until maybe, so just watching the press conference last week, Prof. Van Tam said it will probably be a couple of months after we've done the vaccine that we'll have enough information to talk about transmission and the risk you give other people. So until then, you maintain the same message.
Vic, can I just add to that and possibly comment on the second one? So very pertinent example. My mother is 81 and in a clinically severely vulnerable group, and my dad is 75. And what we've also got to remember is the other stuff that Vic's saying. So when my mum's had her vaccines and she goes home, Dad won't have had his vaccine, but providing they're still following all the things that Vic said, providing they're shielding, providing their household is secure, providing they're not going out and putting themselves at risk from other people, they are contained, they are safe within that space. So providing neither of them are already contagious, having the vaccine won't make them more risky to the other people they come into contact with. But the key is about shielding, staying safe, safeguarding your household, not letting people come into the household that might make you more vulnerable. So I think there's something in there for that. The second thing I just want to say is the whole point of engaging with the connectors is so that we have got role models in the community who are examples of local populations who are advocates for the programme. So having people within this programme who may or may not agree with vaccination programmes but will promote it, having people within this programme who do want the vaccine and do promote that loudly within their communities, within their churches, within their faith groups, is really, really important. So don't underestimate the impact of people like yourselves being in the community and promoting the vaccination. It's really important.
Graham.
Please don't underestimate your impact being role models locally.
Graham.
Can I ask a question, please?
So Sharon and then Tony.
We started the chat already. One of the things that the doctor said was about the ingredients.
Yeah.
I think that's something that's key for people to know what the ingredients are, because again, not knowing what's in it.
Yeah.
Because again, with the flu, we know that you always put a trace of the flu in. But if there's other ingredients, how would we know what we're allergic to if we don't know what the ingredients are? So that actually would be helpful to know what would be in it. And then, but again, everybody's body is going to react differently. But that came up straight away as soon as it said the ingredients on the slide. We're not aware of what would be in it, and would that information be given out to people? Because, for instance, my mum can't. I'm taking it personally. My mum can't take the flu vaccination. So if she was asking about, and I know she's going to, one of the key things for her would be to know what's in it that would actually cause it. Would this new vaccination, and again, it's a new one, would it trigger off some allergies that she's got? So it's, again, certain things about knowing family history and everything else as well. Also, we're hearing a lot about school children being vaccinated. And for me, that would also be the fact of knowing that my youngest grandchild is allergic to everything. So the ingredients at the end of the day would be something that would be would be helpful to know.
So Vic's already said he's going to share the ingredients. What I would really strongly advocate you not doing is trying to explain the ingredients to people.
No.
But it's really important, if there is any concern at all, that you refer them back to their GP.
Yeah.
Or you ask them to talk. There will be vaccine information websites. And it's really important. The thing to remember is that everybody is an individual. And so the vaccination program is a global program. It's for most people, most of the time, in most circumstances. We've talked about this in your training. The NHS does things for most people most of the time that affects most people in the most positive way.
Yeah.
If you know that you have got your own peculiar or individual response to stuff, that is something that you should be discussing with somebody before you take the vaccine.
Right.
But it doesn't mean you can't. It just means that you need to check that out.
Yeah.
Just in the same way that some of the people, I don't know if you remember this, but there was some issue at the beginning of the virus about some people having an allergic or a sensitivity to certain PPE gloves.
Yeah.
And actually, once you know that, you just switch to something that's different. And we don't have just one vaccine. That's the other thing to remember. There are two. So that, and Vic explained that really well. There are two different types of vaccine. So it's entirely possible that if you're allergic to one, you wouldn't be allergic to the other. But that is something you've got to discuss with a trained practitioner. So we've got Tony Bailey, and then we've got Dina. Tony?
Yeah, that was one of my questions about the ingredients, so that's been answered for me, and thank you. And also, I'd like to find out, there's a very good friend of mine who's working in St. Thomas, and he volunteered to take the vaccine, and to his surprise, he took the first one, but he was told that the second one would be given to him 12 weeks after. So, because at first they were saying in the news that the vaccine will be taken, like, the first one will be taken, like, say, today, and then 2 to 3 weeks afterwards, they will give the next vaccine. So I'm just kind of like curious to find out the length of time would that have an effect on the condition of the person.
Yeah, no, good question. So thinking back to how the vaccine works now, and that's why it's really good to have these sort of first principles. So we know that when we give someone a vaccine, we're triggering sort of an immune response in the person, right? So they're creating these antibodies. Now, often so some vaccines are really good that they manage to create a response in the human body that is so powerful that body basically ends up being immune consistently long term, right? So there's some vaccines out there that you can have that. For example, the BCG booster, right, for TB and stuff like that. So there's some that you only need a one dose of. Other ones you'll get a really good vaccine response, which means that you are really well protected, but the length of protection, so instead of being for years and years, might be shorter than that, so months to years. Okay, so for those vaccines, you need to give them 2 doses. You give them 1 dose, that gives you a really good response, and you are protected, really well protected, for quite a while. But then you just need to follow that up with a second dose, a sort of a booster dose, right? So we always talk about booster vaccines when you go for traveling and stuff and things like that. So that's the booster dose that then gives you that sort of second lift and make sure that the immune response stays for longer. And that's in essence the principle of these 2 doses. Now, when the manufacturers and Oxford, Astrazeneca, and Pfizer come out, they can only present what they've done in their trials. So they've done the trials where Pfizer was given one dose and then 3 to 4 weeks later. So that's what they'll present as this is our research based on this. What MHRA and public health and stuff like people like that are doing is they're looking at the actual raw data of who was okay, so out of the people who only had 1 dose, between 1 and 2 doses, how many people got infected? When did they get infected? So what's the true protection of just having 1 dose? How long can you wait till the second dose? They look at all that data, and then they can then sort of make further recommendations on that's how you space the doses out, right? So what they've said is that it's completely safe to do 1 dose now, and then another one 12 weeks later, up to 12 weeks later is actually the wording, right? So then what you've got left is a public health decision, right? You've got a decision where you've got 100 people and you've got 100 doses of a vaccine, for example, right? Now, if you want to make sure, if you're going to stick with your 2 doses in 3 weeks, you can only give 50 people the vaccine, right? So you're saying, okay, I'm going to give 50 of these 100 people the vaccine, and so that they can all get 1 dose now and 1 in 3 weeks, and then we'll make sure they're 95% covered with Pfizer, right? Or you can make the decision that actually we're going to use 1 dose now and make sure all 100 are vaccinated and give them 90% cover or 89% safety, right? And and that's a public health decision, and that's the decision. So based on the MHRA guidance, which says you can actually dose up to 12 weeks now, Public Health England have said then actually we're in the middle of a huge crisis where 60,000 new cases are coming in every day, and we're having 1,000 deaths. It's a much fairer decision now to have one dose and protect as many people as we can and have pretty decent protection. But yes, they absolutely recognize you will need a second dose for long-term immunity. So you will need a second dose, but we shouldn't be using up our supply right now just for a smaller bunch of people. We should be trying to get as many people protected as possible. That's hopefully that answers that.
Thanks, Tony. And Dina, do you have a question?
Yeah, I just really wanted to find out if volunteers who are, not in a clinical environment or doing anything, not a clinical person, are they going to be trained up to be vaccinated as well with the same kind of training?
I would say watch this space. So when it first started, we were being told that yes, there will be this pathway for non-clinical people to also be trained up. Then once we found out the practicalities of the vaccine, and we need to ensure certain levels of safety and governance in delivering it, actually it turns out that mainly it's nurses and pharmacists and doctors who are doing the vaccine at the moment. But you're seeing in the news, there's already talk of these super mass vaccination centers and the military getting involved and stuff. So it's not something I'm aware of locally at the moment, but that might change that non-clinical people get trained up to be vaccinators.
Okay, thank you.
Marilyn, you've got, oh, that's Marilyn to self. Have anybody else got any questions?
Yes.
Well, oh yeah, I did ask that.
Who said yes?
Ed, I've got my hand up, sorry.
Okay.
Just a quick question. Shall I fire off, yeah?
Yeah.
It's just on the merits of wearing visors as opposed to or in addition to masks. The reason I'm triggered to ask is I'm starting a new job next week, and it's face-to-face, so it's going to be really challenging with a mask, but I'm just thinking of the merits of wearing a visor. I see them in the pictures all the time from the hospitals, but I don't see it widespread, the use of visors. Is that something that's sort of really advocated, or?
So basically remember what I said about how the virus sort of enters your body, right? So it needs to get to a point of a part of your body that's mucosal. So either inside your mouth, inside your nose, or the other mucosa is your eyeball. Yeah. None of these are protected by the skin. So the reason you'll see people wearing visors in hospital is the advice we have is that if you're in a procedure where there is a risk of bodily fluids being splashed or sprayed, obviously then you need something to protect your eyes as well. So you'll see people in theatre or in A&E and stuff wearing visors as well. Yeah, but otherwise outside, where actually the biggest risk is not sort of people spitting or coughing fluid straight into your face or blood sort of splashing out and things like that, where the biggest risk is actually touching something that's infected and bringing it to your mouth or nose, or droplets in the air that you breathe in, then actually the mask is the most important thing. And I'm not sure, and I can't be really quoted on this as being like a world expert on it, but I'm not sure the visor alone without a mask will give you that protection, because if you think about it, your mouth and nose are still open to the air, right? So how can you guarantee that air droplets aren't getting in under the visor?
And the same for the gloves. No one seems to be wearing gloves anymore. That's not.
So the thing with gloves is, again, it's about how you use them, and it doesn't create a false sense of reassurance, because if you've got the same gloves on for a bunch of time, then actually if you then bring that glove to your mouth or touch other things, it's the same thing. So if you're very fastidious in changing your gloves after every single contact, then fine, but otherwise it's much more important just to make sure you're washing your hands constantly.
I think the other thing to bear in mind, Ed, it depends who you're working for. So they've got a responsibility to set out in their risk assessment what they consider to be the minimum. And I think most organisations are happy for you to add to that. Just as a pointer for you when you did your training, it's also about proximity. So if you're sitting more than 2 meters away from people across a table and you're not handing them forms or pens to fill things in with, then that's a very different face-to-face environment than one where you've got to actually get very up and close, so you're sharing a screen or something. So I think check out what's expected of you within the workplace as well, and what they expect to do to support you. There was one other, and I've lost.
Yeah, I think I asked Dr. Vic and you, Graham, about the lateral flow tests and the benefits that we should encourage people to have them. There is some doubt about whether it should be frontline staff or people, obviously, or working more face-to-face with, or volunteering face-to-face, about lateral flow tests. That's right, my query was.
Yeah, so lateral flow tests. So the premise of them, obviously, they're rapid testing. So you get a result very quickly, and the idea being that you know, there's a lot of people, like we looked at that triangle, that pyramid. There's a lot of people who have the virus who are asymptomatic, so might not know they have the virus. So the idea behind mass lateral flow testing is that you catch those people who don't know they have the virus and are inadvertently spreading it. From my understanding, and I don't know where we're at with this, Graham, you might know more. So there's certain areas where they're now putting that in place as sort of standard, and that's where there's lots of face-to-face or close contact. So that's in your healthcare centres. That's the thought behind it being put into schools and educational places as well. There was plans for it to be available en masse. You know, when they first did Tier 4, they were talking about Tier 4 having mass lateral flow test centres. I don't know if that actually is up and running, or I don't know of any sites where that is happening, to be honest.
I believe they mooted having one up at Brockwell Park, I think.
Yeah.
And I would just reiterate what you said, Vic. It's more about encouraging those people who don't know they're symptomatic to get a test.
Yeah.
So it's about catching those people. So if we think back to the first wave, and one of the issues at the moment is we're reporting cases because we're doing more testing. That's one of the other things you need to help people understand. Yes, the figures are quite alarming, and that's because we're testing more people partly. So we're finding them. And the thing about lateral flow is that helps us find people that are demonstrating no symptoms at all. So it's still a voluntary thing. It's still something that they need to put themselves forward for, but it does help in identifying people that should be isolating.
Can I just say something? I've got a test actually tomorrow at Brixton at the town hall, because as long as you've got no symptoms and you make an appointment, you can choose your own time.
Right.
So I'm going to go tomorrow, because obviously I'm back out on Monday doing outreach and frontline working. So I'm doing it for my own peace of mind, really, more than anything. I've got no symptoms, but I have actually been around quite a few people who have. So obviously I'm going to go for a test. So as far as I know, there's 3 testing stations running in Lambeth at the moment. One's coming up at Brockwell Park, Brixton.
Is this for the lateral flow, Dina?
What's the difference?
Well, the lateral flow, it's a different type of test. It's the one that there's been some press about not being as reliable as the ordinary test. But it is primarily for helping people who may be asymptomatic identify themselves as being a carrier, for want of a better term.
Yeah, I think possibly. I don't know, to be honest.
It's the rapid test, Dina. It's the rapid test. So if you've been told you get the result the same day or that time, then that's probably the lateral flow test one then.
Okay,
whereas the PCR ones are the ones where you go in and they swab the back of your nose and the back of your throat, and then you get a text 2 or 3 days later, and that's usually.
Oh right, sorry, I wasn't aware of the difference. I've learned something new today.
We're just hearing from Jean that the lateral flow test in Windmill Gardens is now open from 9 till 3:30 and can be booked. I just also want to say the last 3 or 4 slides that Vic shared, I'm going to do with everybody on the safari on the 19th of January. So not so much the technical virology detail that he did at the beginning, but the stuff about how to deal with people, how to reinforce the messages, I'm going to do again on the safari. So it'll be an agenda item on there. So if you know people within the Connect programme that are struggling with that, point them to the safari, and if they only want to come for that bit on the Zoom, that's fine as well. Tony, did you have a question?
Yes, please. The question I'd like to ask the doctor is, a lot of people have been asking me this question, is the question goes like this, that basically with the new mutation of the virus, with the current vaccine safeguard people against the new variant of the virus?
Yeah, no, good question. And so the answer to that is we're very confident that yes, it will, basically. And that's, again, going back on understanding the principles of how the vaccine works. So remember, now you get, hopefully, that what we're doing is we're giving the body a small bit of RNA to create a small segment of the virus, right? And that small segment of the virus, then the body learns how to recognize it and deal with it. So we know what we're telling the body to create with the vaccine. So we know what part of the virus that is, and we also know where the mutation is on the virus, right? So looking at where the mutation is and looking at what we're telling the body to do with the vaccine, we are pretty confident that even with the mutation, the vaccine will still work. The segment of virus that the vaccine creates and that our immune system responds to will still be strong enough that we'll still have an effective vaccine response. So that's why everyone's pretty confident that the vaccine will still work. Okay. Guys, I need to actually go quite soon, actually. So was that helpful? I mean, maybe it's something to feed back to Graham when I'm not in the room, but yeah, the level of what I talked about at the beginning, because I know it was quite sort of dense at the beginning and stuff. Is that useful?
Very, thank you very much.
Very good, very good.
Yeah.
No, because then I can do this with other communities and other cohorts as well. And as I said,
so about knowledge, once people know, because sometimes people are ignorant because they haven't got the knowledge.
Yeah.
But once they get the knowledge, they could explain and take it forward. So thank you for giving us that knowledge.